I would say good morning, but I know for most of you it's moving toward the afternoon. But I'm very happy to be here to talk about something that has changed all of our worlds, certainly mine, and at our facility at the Center for Trans Youth Health and Development. So for folks who don't know, our center is based out of Children's Hospital Los Angeles. We have been doing trans youth care since the mid-90s, and we have about 1,700 active patients. Of course, we've had many, many patients move out into adult services when they turn 25. So I'm going to talk a little bit today about some important facets. I hope that this is of value to you. And some of it's going to be general. So today I'm going to cover, and then I'm going to hand it over to Aydin, but I'm going to cover a little bit about the positives of using telehealth for trans youth care, opportunities that are being presented now because of this new and strange landscape. I'm also going to talk about some of the results that providers gave me when I sent out a survey in early April. And then I'm going to talk about some of the tips and tricks that we use at our program for successful trans youth care via telehealth. Okay, so let's get started. One of the things that's exciting, I sort of think back of this, and don't blame me for starting the pandemic, but in the beginning, very beginning of 2020, I had told my team, I want to be doing telehealth by the spring. I had no idea that we were all going to be doing telehealth by the spring, but to me it was really important because, as many of you on this call know, access to trans youth care is very limited in this country. And so it's important that people who are confident and feel great about this work have the capacity to provide services for people that wouldn't normally be able to get in for care. So I think this is, I'm going to move the panelists over for a minute. I think this is a really great opportunity to provide health education and preventive care for high-risk populations, vulnerable youth such as trans and gender diverse young people. I think that we have the capacity to improve care and capabilities in rural areas. Sometimes they have limited broadband connectivity, but we can do other things like phone, but we can certainly, and I think we'll see an increase in the broadband capacity all over in every area. We can provide behavioral and mental health services in these one-on-one scenarios or in group settings that patients can join from their very own homes. We can reduce travel and provide cost-effective continuing education training for healthcare professionals, such as we are doing today. So some of what is important for good telehealth visits with trans youth is really across the board good practice for any telehealth visit, or even any Zoom meetings or other types of platforms that you're using. So we're going to go over some of them, and some of them are real no-brainers, and I want to acknowledge that because we've now all been doing telehealth for 6 months. So many of us know this, but I want to just go over this because it's a good reminder. Test out your webcam. We learned that this morning as we were trying to get all of us on the panel onto this. Make sure that your volume's on. This is a really common one. Try out your microphone. Your computer will allow you to do that. Plug in your computer. This is something that's really important because you don't want to lose power during your visit. Use a wired internet connection. That's not in some places. For many of us, our wireless is a very solid and good connection, but if it's not, that's really important to wire in. Close unnecessary programs. So if you have a lot of things going on your computer, it will slow down the rate of transmission. Use the right browser. All of these things are pretty important and pretty obvious. Dress appropriately. I know this has become harder and harder for me as the time has gone on, because having different sets of clothes in your own household is kind of strange, but it is important, especially if you're doing patient and client care, that that person that's on the other end of the video screen knows that you're taking this visit seriously. Find a quiet space. Sometimes that can be hard. A lot of us have children at home. A lot of us have pets and animals, other street noise. It's important to try and find a soundproof area as much as possible. Adjust the lighting. I'm going to show you some examples of this just to give you an idea of what I'm talking about. For patients, really understanding in the patient complaint beforehand if that's possible. I know sometimes it's not. For trans and gender diverse young people, usually they're contacting and having a visit related to their gender, so that's not as pertinent. So within your physical space, have the camera at a height that it can be angled slightly down on, right? So I'm going to show you some examples of this as well that sometimes people are missing on this. Don't be too close to the camera or you end up with a distorted face like this. You don't want to do that. Make sure your camera isn't set to a wide angle because that will have the same effect. It will sort of make you look like you're in a fishbowl. Think about what's behind you or use a set background in your platform. So most programs have the capacity to set a different background that looks slightly different. I'm moving, you could probably see this, I'm moving my faces around so that I can look at what I look like as I'm sharing these tips with you. Okay, face your greatest light source. So if you have a window, that's the best lighting. In my particular scenario, I have a door and windows behind me, but I also have a window in front of me, which is providing natural light. You can also get specific lights that will front light you and make your face look not ghastly. So there's a great, if anybody's on Twitter, there's a great Twitter feed called Rate My Room. And they basically, what this person does is, as pundits are talking about political things, they rate what's in the background. And I think it was a good reminder for us as providers, just look at some of the things that this person makes recommendations on. So I pulled some of the funny ones that I thought were important. So look at this. This is not a great background. You can see that this person has, first of all, their lighting is terrible. Their face is being lit by the computer screen, which tends to send a terrible looking light. You can dim the light on your computer if you have glasses and it's bouncing off. Here's a good example of that. I'm going to dim my computer and you'll see the difference. My computer is providing some light for my face. So this is not a recommended background, what you see here. I thought this was really funny. Oh dear God, organizing rescue mission, blink twice if you can hear me. So this is Beto O'Rourke. And I mean, it really looks like he's kind of in his basement. So I don't know what's happening there. And this is the handle, Rate My Skype room, if you want to check out that particular person. This was a 9 out of 10, good balance, nice shelves. So this is Camilla Parker Bowles. You can see that there are flowers in the front ground, there's pictures, there's interesting things to look at. She's lighted relatively well and has books in the background as something to look at rather than a blank room. So these are just some great examples. And if you want to see more of that person, you can go to Rate My Room and look at it. So here's some examples. I really like this person. He did a whole blog on proper lighting. So you can see in this, this is bad lighting. He's backlit and his window's behind him. You can see that he shades the window here and puts the lighting in front of him. This is from Springboard Website Design, giving tips on good telehealth visits. This is another example. I love this lady. She said, try to avoid the zombie telehealth look. There's a couple things that are problematic with this. One is obviously the only light source is the computer screen. And also the positioning of the computer screen means that you're looking up her nose, which is not a great angle to look at someone. And she does a couple of tips. She changes her makeup, she changes the lighting source, she goes with a different background, and you can see that there's a very big difference in the way that she looks in this final picture. And this is, and let me move this over a little bit, Leanne Cassaboy from PC World. So I thought those were some good little tips for us. Something that is challenging, I think, especially if you're working at home and you've moved to a different workstation and maybe you're on a laptop, maybe at work you have a desktop and a double screen or something like that, but you usually have more access when you're at a work desk than you do have at home. But there's some things that can be helpful. You know, share your screen if you feel like it's necessary, right? So there are many occasions where you might want to share information with your patient or your client. Have the patient history on hand. So if you can be on to that person's chart, although you do have to look away to look at that chart, you can tell the person that you're looking away to look at something in the chart. Let's say you're looking for a testosterone result or an estradiol level or something like that. Just remind the person, I might be looking away, but I'm going into your chart to look. If you have two computers, that makes it even easier because you can be checking their chart on another computer. But most people don't have that situation. Another thing is sometimes for me in my practice, what I have when I do an in-person visit is I have that person's chart in the room with me. So if I want to take notes, I can just take notes while they're there and they see me taking notes. But in a telehealth visit, they're only seeing you from the shoulders up. So if you're taking notes and you're looking away, for example, like something like this, and you're writing something down to remind yourself, just communicate that you are going to be looking away from the screen. I always make jokes with my patients about this, like I'm taking notes because I'm old and I'm not going to remember everything, and I want to make sure that I take care of everything we've talked about today. Don't forget the lag time. This is, I know that Aydin's going to talk a little bit about this when he speaks, but that's really important. There's sometimes a delay between when you're talking and the other person is talking. The most hilarious versions of this are when we're watching the Rachel Maddow show and she's communicating with a guest and they're talking over each other. Follow the same clinical guidelines you would with an in-person visit. And we're going to talk more about this because I think this is a little bit more challenging with trans and gender diverse youth in particular. Stay engaged. Don't multitask. Don't go on your phone. Don't catch up with your Scrabble. Don't do anything when you're else besides being present with the person on the other side of the screen. It's not, you wouldn't do that in person, so it's not fair to do that when you're on a telehealth visit either. Explain the next steps. This is a really, what I've started doing with my patients is I will say, okay, what we've talked about today, my homework is to order this, to order that, and send you this or email you this. And your homework is to, and explain that and ask them to tell you back what you have said. That's really helpful because a lot of times people don't know what their next steps are. Do they make another telehealth visit? Do they make an in-person visit? Are they going to get labs? Are they changing their dose? So all of those things are really important to explain. There's a whole body of literature on what makes a good telehealth medical provider, right? So I really liked this. Somebody said, you know, having a good website manner. What does that mean? So direct eye contact is really important and active listening is really important. But the sort of third pinnacle of this is empathy, right? Utilizing facial expressions and eye contact to connote empathy to the person on the other end of the screen. And this is partly because we don't have our bodies to help us connote empathy or display empathy for our patients. We only have from here up unless you go way back, which is weird and don't do that. So I think having a good website manner, we're going to revisit this in a minute. So I did this, I really was interested in finding out what people were doing around trans and gender diverse youth care at the very beginning of the pandemic. So I sent out a survey, and some of you on this call may have gotten this survey and participated in this. It really was a QI project. I'm changing it into an IRB approved project to get follow-up data. There was no HPI or personal information that was collected on that survey, except in the very beginning. I was trying to figure out if there was a difference in the ages of people in their response to telehealth. So that data was all removed, and I categorized people by age blocks. But I wanted to share some of those results. And just so you all know, this data hasn't been shared anywhere else. So this is brand new. Much of it is not going to be surprising because you're all having your own experiences. But I think it's important that people understand that doing trans youth care over telehealth presents some very unique challenges. And so I really wanted to see what people were thinking about that and how they were responding to that. So I asked the question of people, you know, how comfortable do you feel about different things in person versus telehealth? And so in this particular question, I was asking about how comfortable do you feel providing new patients gender-related healthcare in person? And in this one, the turquoise bar represents in person, and the magenta bar was then the question that was followed up, looking at telehealth. And you can see, not surprisingly, right? So most people are very comfortable providing services for new trans and gender diverse patients in person, 92.6%. But that number drops down, and most of those people moved over into the somewhat comfortable category on telehealth. This data is collected from, I had 126 participants, but this particular data that I'm showing you are from 58 medical providers who were also providing telehealth. So that's the data that I'm showing you right now. There's so much data and I have so much more work to do, but I want you to understand that this particular cohort that I'm talking about are 58 medical providers, prescribing practitioners who are doing telehealth care, who were doing telehealth care in the first week or 2 weeks of April. So you asked about continued care for trans and gender diverse youth. And not surprisingly, people were in general more comfortable with continued care than they were with establishing new care. A little bit, a small number of people moved from very comfortable to somewhat comfortable. Okay, so in regards to specific practices around trans and gender diverse youth care. So I asked the question, how comfortable are people with continuing puberty blockers for young people that they had already established care in? And then what about new people, which will be the next slide. So the green bar is in person, the orange bar is telehealth. So some of this has to do with people's just baseline comfort providing gender affirming care and medications and blockers specifically, right? So you can see that, 78.6% of people are very comfortable continuing blockers in person. That drops a little bit to 73% on telehealth. And more people moved into the somewhat comfortable category. What about new blockers? So in person, people felt very comfortable. 76.8% in person, people felt very comfortable providing patients who are new to blockers. This dropped pretty significantly for telehealth because of some of the complications that I'm going to talk about later, but I just want to show this. Look how many people popped into the somewhat uncomfortable range. I think that's interesting. Let me just see, somebody put something in the, oh, Beto. Oh, that was sweet. I love Beto O'Rourke too. That was a couple slides back. Okay, so here we have continuing estrogen. So the green bar is in person and the purple bar is telehealth. I'm not sure why more people were comfortable with this in telehealth, but I don't know if it's something about the survey or the order of the survey. But you can see that most people are very comfortable continuing estrogen in a patient that they had already seen in person on telehealth. What about new estrogen? Okay, so this is a person that's you've never seen before and they're coming for care via telehealth and they want to initiate feminizing hormones. You can see that there's many people who bumped into the somewhat uncomfortable and somewhat uncomfortable category here. This is pretty similar across the board. So continued, and just in general, people have more comfort with testosterone prescription, probably because there's so many transmasculine young people in care. There's about a 2/3, 1/3 ratio of transmasculine to transfeminine people. So I think people have gotten more comfort with testosterone. You can see here again that there's a lot of comfort with this continuation of care with telehealth. For new testosterone, that changes. So you can see that patients who are coming in, even in person, there's a lower comfort level, right? So the 89% in person, comfortable, very comfortable starting testosterone drops to 44% with telehealth. I might sneeze, hang on. We are inundated with a lot of smoke right now. We have the Bobcat fire that's very close to our house right now. So we have a lot of smoke in the air. So sorry about that. Somewhat comfortable, 28% new testosterone on telehealth, but somewhat uncomfortable, 15%. Nobody related that they were very uncomfortable. So we also I asked some questions about what people felt like telehealth versus in-person visits around certain aspects of care. So this was the response about patient engagement. Did people think that telehealth compared to in-person was better or worse? The most popular answer was that in-person was somewhat better than telehealth for patient engagement. There are a handful of people that really love telehealth, and they believe that patient engagement is somewhat better than in person. I'm going to show you a couple other aspects. So parent or caregiver engagement. So people definitely were either bent to about the same, but mostly in person, somewhat better than telehealth. And I'm going to show you some of the qualitative answers that people talked about why they felt maybe parent or caregiver engagement was not as good on telehealth as it was in person. Asked about provider engagement. So, 35% of people said in-person is somewhat better. 16% said that in-person was much better. Again, the most common answer was about the same. Telehealth has about the same as in-person in regards to provider engagement. What about the quality of the relationship between the provider and the patient? So again, we see the most popular answer was in-person, somewhat better than telehealth. And then the next, telehealth about the same. Nobody on this said that they thought that telehealth was much better. There were people that said it was somewhat better. What about convenience? So convenience for families, most people agreed that telehealth was much better than in person. Nobody thought that in-person was better than telehealth around convenience, and that's obviously because people being able to sit in their own homes and have their visits is much easier for them. Provider efficiency. So this is interesting. This is really split, right? So a lot of people did feel like telehealth was much more efficient for them than in-person visits. Most people thought it was about the same, and there were less people who thought that in-person was more efficient than telehealth. I asked this question, again, sorry, I have to move my head around here. Asked this question about acceptability, appropriateness, and feasibility. What was really awesome was that the majority of the sample agreed that telehealth is acceptable, appropriate, and feasible. There was one person who disagreed that it was appropriate. So I think this data right here in this chart is really important for us when we think about continuing telehealth outside of COVID, beyond COVID, using telehealth as a mechanism for expanding services or making services more available to folks. I asked people about their perceived capacity to demonstrate empathy through facial expressions and also through tone of voice. Most people felt that was very or somewhat easy for them. There were a few people who felt that it was hard. Maintaining eye contact, people felt really good about that. And again, this is the provider perception of their own capacity to maintain eye contact and practice active listening. There were a few people who felt like it was difficult for them. Here's some of the qualitative answers about the advantages of telehealth. So convenience for families who have to travel, that seems pretty obvious. Improved access for youth with less family support. So this was interesting, sort of indicating that families who were less supportive or parents who were less supportive were less likely to bring their young people for in-person visits, but they felt more comfortable with letting their kid do telehealth, maybe because their effort was less. Flexible scheduling. This is really, I think, has been key for me. It's, if patients have certain requirements, especially now that school is back in session, I think we all experience the joy of kids having nothing to do over the summer, so being very available. I don't think it was great for the young people, but it was great for us as providers. Youth are just in general more comfortable at home, especially the younger generations. They just, this generation of kids has grown up in very tenuous and uncertain times. As my kid likes to tell me, what do you expect from a generation raised on Hunger Games? And so they just do have, a lot of them have more comfort at home, particularly trans and gender diverse youth. I think that we see a disproportionate number of TGD youth who want to experience homeschooling. They're very uncomfortable in a school environment. So for them, they are able to participate in their medical visits online, and that's really great for them. It provides us as a capacity to provide care during a pandemic. That's a big deal. We want people to be safe as possible, and if we can continue the continuity of their care via telehealth, that's an advantage. It's more efficient than in-person team visits. I think in programs that have a very long and complicated process when that young person comes in, it might be more efficient. They can, in my program, we book out 2 hours for new visits. For the first hour, they're with our intake coordinator, and the second hour, they are in with the medical provider. We can check on patients more frequently. Hey, can you pop onto a telehealth visit? In some scenarios, like it's complicated. So in my particular clinic, you know, they have to get, if somebody has a different primary care provider and an HMO, they have to get authorization. If they get authorization for an in-person visit, they have to get reauthorized for a telehealth visit. So it's not always that easy. For patients with PPOs, it's much easier to get them spontaneous visits. There's no physical exam. Right? And that's probably a benefit for all youth, but for trans youth, that's a huge bonus, right? So for us as providers, sometimes we see that as a disadvantage, but for young people, it is a huge advantage. It gives us as providers a little bit of capacity to assess safety in a patient's home. You can ask about their environment. Oh, tell me about that artwork on your wall. Tell me about what's happening. If somebody's hunkered down in like in a little hobbit hole, we might be able to learn something about where they're spending most of their time. I don't agree that this is an advantage. I don't think you should multitask while you're doing telehealth visits, but I do think that in between telehealth visits, you can address other things for work like email and things like that. I'm sure that's what this person meant. Patients tend to show up on time. Because there are not issues, especially in Los Angeles, there's not traffic. There, you know, when patients are at home, there isn't traffic, which often creates a huge problem with patients being on punctual for visits in person. There's an increased show rate. I had 100% show rate in the first 3 months of telehealth. I've probably done about 200 telehealth visits now since April. Youth are comfortable with video communication. There's decreased exposure in the office. So young people don't have to worry about being stared at. They don't have to worry about being misgendered or the wrong name used. They don't have to make decisions about the bathroom when they're in the office. And so they have some additional, diminishing of those potential problematic things that could happen in an in-person visit. So what did providers think were the disadvantages? Technology limitations. So people certainly acknowledge their own technology limitations, but also their patients. It's difficult to conduct multidisciplinary visits because you have to plan that with everyone so that everyone's either on the call together or sequentially on the visit with the patient. For people who use standardized screeners, they were more difficult to administer. I think you have to consider other techniques, and we're going to talk about some of those. Potential loss of a parent-provider relationship. So I think we tend in this work to err on the side of confidentiality. So maybe we create a confidential space for the young person, but then we don't reconnect with the parent. We can't get vital signs. This is really problematic for a lot of physicians. They really have trouble not having those blood pressures and those weights. And I think that those vital signs can be important, but I also think it's valuable for us to ask, you know, do we really need vital signs on people that we haven't experienced problems with their vital signs in the past? There's also ways, and I haven't looked at this data yet, but I did ask the question, are you asking patients to get their own vital signs? Potential issues with safety and confidentiality. So I think this is really important. Aydin's going to touch on this a lot, because for therapists, it even becomes more critical that those confidentiality spaces are maintained. It's really hard to pick up the body language of family members. So when people are in person, we have a great capacity to be able to look at their body language and make some determinations or some assessments of how comfortable they are with their young person's gender and with moving forward with interventions. And we lose that capacity with telehealth. We might miss the opportunity to see things like evidence of self-harm. And we do a physical exam and we look at someone's body, so like their arms and their legs are places where we know young people are very much more likely to be practicing self-harm. We miss that in a telehealth visit. We have less access to STI and pregnancy prevention conversations. So we have to come up with creative ways to do that. Obviously, we can't do Tanner staging via telehealth. That can be problematic. I'm going to talk about that in a minute. Consent issues are challenging. There are federal restrictions on controlled substances. So this is a really critical for people who are prescribing testosterone. The federal regulations are such that you are required to have at least one in-person visit with someone to prescribe a controlled substance. However, the caveat to that law is that when there is a national emergency, that requirement has gone away. So while there is a discrepancy between what is coming out of the White House and what they believe to be an emergency, the fact remains that we are technically under a national emergency. And so these restrictions have been lifted. So you are absolutely legally allowed to prescribe controlled substances, even when you have only met someone via telehealth. So that's really important for testosterone prescribers. Insurance reimbursement. You know, I just hate everything about this, but there certainly has been improvement in what insurances will reimburse, but a lot of times they won't reimburse if you lose your video, right? So if you lose your video and you're just doing an actual phone interview, that's not going to change until the new year. And in the top of 2021, they are going to change the law about that, and we'll be able to be reimbursed for just phone conversations. I think this whole thing is being recorded, so the slides will be available in that recording. That was an answer to somebody's chat question. I think, you know, people put that new patients are challenging. I think that's true. I think we've all learned to rely on a lot of things in the in-person visit that are not available for telehealth. But I do think based on the results, people felt pretty comfortable doing new visits. Some young people have a difficult time seeing their face on the screen, and Aydin's going to talk a lot about that. It's dysphoria producing for some people, and talk about some of the ways that we might mitigate that. This is still a big problem. Patients out of state, like if you have patients that are your established patients, but they're out of state, maybe you were seeing them in the context of school, they were in college in your area, but now they're back home with their parents. You cannot practice medicine in another state that you're not licensed in. I do have to tell you right now, there is many states are offering emergency licensing. For example, I have patients in Alaska that normally would fly down to Los Angeles. I'm emergency licensed in Alaska and working on multiple licensure across the country, but that's something that you can look into. And I think for mental health, the laws are a little bit different. This went around on the pediatric and adolescent transgender health listserv, and somebody talked about it's really the patient's place of residence that dictates whether or not you can provide care for them. So it's a little bit different for behavioral health. All right, let's talk about some tips and tricks. So, it's always my policy to acknowledge awkwardness, right? It's new, there could be potential discomfort. Telehealth is a new way to do this very intimate work that we know is very intimate and creates vulnerability for the young people. So just starting out the visit with that helps do two things. One, it helps you get the permission or consent to do a telehealth visit. So part of documenting a telehealth visit includes documenting that you have talked with the patient about consenting for a telehealth visit. So you can offer things like, oh, how are you feeling about telehealth? I know this is kind of different. We haven't really done this before. It's also really important that we don't neglect asking about COVID. And this is really not as much related to telehealth, but I think it's related to the healthcare of our young people and their families. Every single visit, I will ask someone, have you or do you have any coronavirus symptoms? I'll go through some of the symptoms with them. I will also ask if anyone in their family has symptoms, if anyone's been diagnosed with COVID-19, talk to them about, do they know where they can get tested if they do have coronavirus symptoms? And also, so important, assessing for housing and food insecurity, because a lot of people have lost their jobs. They may be struggling with this and they're not going to offer up that information unless you ask. And usually most centers have resources around this. Don't ask if you are not going to look up resources for that person or don't have those resources, but get those resources and then do ask. Get a good telephone number to call back if the connection is disrupted. People change their phone numbers all the time. Sometimes what you have in your chart is not the correct phone number. And a lot of times when people are scheduling WebEx or Epic or whatever mechanism you're using for telehealth, get a good callback number so that you can connect with that person and you don't leave them hanging. Oh, sorry. I'm just going into the chat real quick to look at questions. Make sure that you secure a confidential space for the youth. So usually, the requirements around telehealth for minors is that a parent has to be present. You need to see them in the beginning of the visit. Then you can say, I'm going to talk with your young person by themselves. And then I'm going to ask your young person to bring you back into the visit toward the end so that we can cover some of the things that we've gone over. Of course, like any visit, make sure you check in with the young person that they're okay with you sharing the things that you need to share with the parent. If you need to get home vital signs, so for example, let's say that someone has been struggling with high blood pressure, encourage that person to either get a blood pressure machine at home or stick their arm in a blood pressure machine at Walgreens while they're wearing a mask, while they're social distancing, so that they can report that back to you. Either they can send that information back through the patient portal if you have that, or however you communicate with your patients outside of visits. The one that I do this most frequently with is height, because I have a lot of patients on blockers and I want to see if they're growing, if they're moving forward with hormones. I want to see how to titrate them. And so I will ask them, can you right now stand at a door and get a tape measure and tell me what your height is? Same can go for weight. Is the patient's perception that they've gained or lost weight? Do they have a scale in their home? Don't presume that people have all these things in their home. Ask them first. Come with create creative ways to share information. So for me, I've done so many new blocker visits on telehealth, and finally I just created a very specific PowerPoint that talks about blockers and shows the mechanism of blockers that I do a share screen with my patients. And so it wasn't working for a while. What I was doing is what I would do in person, right? Which is to draw some crazy sketch and hold it up to the camera. And that actually is a really bad way to do it. We have technology to use for creative ways. And so now I do a shared PowerPoint presentation where I talk about how the blocker works, how puberty works, what the blocker is going to do. And it's very, very helpful. Patients can take screenshots. They can ask questions. It's very helpful for them. You can do that with other things as well. I keep my prop bag with me so I can hold up the blocker implant and show them. If I'm intaking a new trans feminine person, I have my orchidometer with me and I can show them. Make sure that you remember that things get distorted with the camera, right? So the blocker implant can look like it's this big in the camera. And so it's important to put it up to something like a quarter or show them the size relative to something else. Talk about dimensions, things that might look strange over a camera that they can't touch and feel. But have those things available so that you can help facilitate your visit and they can understand. Don't ask young people to show their bodies over telehealth, even if they're offering. That's a really problematic issue. You do not want someone to show you how much breast development they've gotten. You don't want somebody to show you how much breast development they have and don't want. That is a very slippery slope and is actually categorized as pornography. So really be careful about this. If it's really important for someone, for you to look at that person, determine if they have, let's say, pubertal development, have them come in and see you in person. Most of us are doing some in-person visits, but if that's really important, schedule them for an in-person visit. Consent forms. This is something that people have a lot of, like, many people use consent forms for blockers or hormones. My recommendation is that you don't stop using consent forms if you use them. If you don't use them, this is not a problem, but it's also an opportunity for that family to have that consent form in their personhood, right? You can email them the consent form, they can have it digitally, but then the question becomes, how do they send it back to you, right? So this happened to me. I had a young person who was starting blocker, or I don't know, hormones or blockers. And I said, you know, I'm going to email you the consent form. Can you sign it and then take a picture of it and send it back to me? Well, they didn't have a printer, so they couldn't do that. Right. And that was so the mom said, well, I'll go to Kinko's, and it was very long and complicated. I'm going to show you what we did to solve that problem. What I did was I actually got a DocuSign account so that you can get digital signatures. It costs a little bit of money, but it saves you a lot of pain and energy and snail mailing. You can always snail mail if you want to, but you definitely, if you can do it digitally, it saves everybody a lot of time. So labs, how are people getting labs? So some people are in our situation here in Los Angeles, we consider gender work still to be essential services. So all of us go into work at least one day a week. Our nurses are there every day of the week. And so people can still come in to get labs if they're more comfortable doing that. But a lot of people were sending out to Quest. That means this is very provider dependent, but in our practice, if somebody's going to get labs outside because they have an HMO and they can't get labs done at our facility, we would give them a paper that we checked off all the labs that we want, says fax back to us. That's obviously, you can still do that digitally. You can have a digital copy of that lab form that you can fill in for that patient. I've found it much easier to input that person's information into Quest or LabCorp and then email them. If you use Quest or LabCorp, what happens is it will spit out a lab form with a barcode on it. They can just take that to an outside lab and all their information and whatever labs you want are already in the system. It's much easier. And then when they're coming for repeat labs, all their information is in there already. So consider doing something like that. Extra visits. If you need extra visits, do extra visits, right? Let's get on another telehealth call so we can continue this conversation. Sometimes patients are really complex and you need more time. It's really important that because we have more flexibility with digital medicine, we can get people in for extra visits. Keep a paper by your side to keep track of what you need to do. Nothing's worse than like not doing what you talked about you were going to do. So if you gave yourself homework and you're going to email them a consent form, or you're going to email them a Quest or LabCorp lab slip, write it down so you don't forget it, because you could do these things back to back all day long and completely forget what you were going to do for that young person. If you can get into their chart and do all those things right after, that's great. But remember, you don't get reimbursed by insurance companies for charting. You only get reimbursed for the telehealth minutes that have transmitted. Have digital information available at the ready to email to the family after the visit. If you don't get enough time to talk about things, say, oh, I'm going to email you information about this. I'm going to show you some examples. I'm going to also provide you, if you don't have this in your system, links to injection instruction videos, because injections, normally what would happen is someone would come in, they would get a teaching visit, they would try to do it on their own. If they're okay, they can do it on their own. But, you know, not everybody feels comfortable coming into the office for that. So maybe they come in one time, or maybe they're not comfortable at all, but they can link to these videos where we do samples of intramuscular and subcutaneous injections. Connect people to support groups. There are a lot of support groups now that are available even across states because they're digital. That's really exciting for parents to be able to get into support groups and for young people as well. Here's some examples. This is like what my Quest portal looks like. Then you can just go into it and you can find the results. It's really easy. There, you know, you can type in the person's name and search. You can just click on one of these things to see what's going on with your patient. Once you've read it, you can mark it as reported or reviewed. And then if the patient needs that information, you can utilize that as well. What's going on in the chat? Oh, look, that's great. So one person saying our clinic's been using DocuSign to send consent forms. That's perfect. Forms can be sent to multiple recipients, which is really helpful if you have a family with parents in different places. And then Out Youth and the Transgender Wellness Program are running virtual support groups for both youth and adults, and now more than ever, right? It's a very tough time. Here's what the DocuSign looks like. You can drop your PDF into this and you can send it for multiple signatures. If you have their different emails, it can go out to both of those different places. It's super helpful. This is what we have. So one of the challenges for people who are doing injectable medications, either testosterone or estrogen, is supplies. So I don't know why, but there just seems to be a problem with pharmacies getting injection supplies. We've moved to recommending people get their supplies online. There's a company called Tiger Medical. If you want to screenshot this, or you'll get it in the recording. There, we've put all these links to different injection supplies. And I mean, you can get, you know, 100 syringes for something like $13. It's worth the aggravation of not having to go back to the pharmacy and get the right thing, because a lot of times the pharmacy will give one needle and a syringe that's combined and people don't know how to take it off, and it's complicated. But you can give them these links. I will email these out to people, patients and families, so that they can just get all their supplies in bulk, and it's much easier. This is the link to the injection videos. If anybody's interested, you can screenshot that, or it will be available in the recording. These are videos where that we made where I'm doing samples of these injections, not with hormones, but with water. But if you want, you can utilize these. Okay, that's about it for my session. I'm going to hand this over to Aydin, and he's going to share with you some of the things that he has learned. If we have time for questions at the end, we'll take some more then, but you all can reach me at this email address down here, jolson@chla.usc.edu. I hope this was helpful and that you gained something from it, and I'm going to hand it over to Aydin right now.
Okay, so Joe and I are married and we live together, obviously, and so we work in the same space. So I had to come from the dining room, and now she's leaving the office. So thank you for being patient on that little transition. I think I want to preface this by saying that when I think about some of the things that, like, around best practices for this, I think we're all still learning. Maybe some of us feel more competent or comfortable doing this work now, maybe than we did when we first started doing it in, the early spring, whenever you all, or if you even maybe move to online platforms only. So I'm going to run through some things that I have learned, some things that kind of frame the idea of the environment they're working in, that we're working in, and also maybe thinking about the environment that the people we're meeting with for therapy are working in, because I think it's important to understand that. So I'm Aydin Olson-Kennedy. I'm a licensed clinical social worker and the executive director of the Los Angeles Gender Center, who provides mental health, individual, family, group support to trans and non-binary communities in the greater Los Angeles area. And since moving to telehealth, we have certainly expanded. We have folks who are accessing our services in a variety of places across California. And so Joe had mentioned that one of the upsides of this is that increased access, and we've certainly experienced that as well. For points of disclosure, I think it's really important that people know that I am trans myself. And so some of the things that I'm going to talk about are things that I've learned from my clients and from doing this work, but have also been guided and informed and sort of supported by some of my own experiences, even though I transitioned many years ago, specifically as it relates to talking about gender dysphoria. So let me share my screen. Okay, minimize folks. Got it. Okay, so the introduction slide. So what I want to start with is, hang on one second. Okay, there we go. Is that when I was sort of thinking about some of the experiences that I've had as I've been doing this work, and some of the challenges, even while Joe was presenting, this is the back door to our backyard, which is where our dog absolutely assumes that she needs to go in and out at her leisure. And so while Joe was speaking, I was like crawling on the ground in the backyard, trying to coax her in and out so she could go to the bathroom. And so there are just things that happen in our environment that we're having to figure out that wouldn't necessarily happen when we were working in an office or an organization or agency. And so I found this quote from this woman in, I think it's Australia or New Zealand, and she's sort of talking about the idea of her new experience from working at home. And so I just want to share that with folks. So here's the scene. I'm halfway through a 3-hour Zoom meeting. My 5-year-old daughter is cutting her Barbie doll's hair for the 4th time, even though I have warned her the doll's hair will not grow back. My 11-year-old son is sitting opposite me, moving my 4 cups of half-finished tea to the side while trying to get my attention by mouthing, "How do you say I like to build Lego in Afrikaans?" My camera is on, so I look over the consummate professional, but my head is spinning and I'm ready to tell my colleague on the other side to mute his mic for the 6th time because I can't deal with that email notification tone. While all this is going on, I remember that I need to cook dinner and hand signal to my son that it will be frozen chicken nuggets again tonight, which is met with an eye roll from Edward Scissorhands on the floor. While it might seem like I don't have my shite together, I actually do. This is just a normal day in my new normal life. Now I'm not a big drinker, but right now I could do with a bottle of homebrewed pineapple beer to get me through the day. My home is no longer my safe haven. While I've worked from home for several years, this version of working from home is something out of a bad sci-fi movie. I am reliving the same day over and over, just with good Wi-Fi to surf for memes to cheer me up. Before COVID-19, I enjoyed working from home. I had my days perfectly planned out. Get up at 5 a.m., check urgent emails, do a morning workout, make school lunches, get kids up at 6:30 a.m., get them off to school by 8, and get back home in time for my 8:30 a.m. team check-in via Skype. My meetings and work were perfectly balanced. I would break at 12:45, race to get kids from school, and be back by 1:45. Kids would settle in, do their homework, run wild outside, and allow me to carry on with my workday. By 5 p.m., I would do my final team check-in, close the computer, and continue my duties as a mother and wife. Now all my neighbors are here, some with far too much money because home renovations are never ending. Some have rediscovered their love for rock music and want the entire neighborhood to listen. Others have decided homeschooling consists of 80% outside time for their rather vocal kids and 20% being indoor learning. I have a Karen in my neighborhood next door group who constantly updates us on the neighborhood gossip and sells Avon products. But it's not just that. I am now a cleaner, nanny, wife, teacher, friend, and yes, a senior manager with a strategic portfolio that I need to excel at. Many of us have realized, as nicely put in this tweet, that we are not working from home. We are in fact living at work. I wanted to share this because when I first started doing telehealth, I found myself to feel exhaustion in a new and different way. I think many of us can relate to when we have very packed clinical days, when I'm seeing 6, 7, 8, 9 people back to back, and maybe I have done a poor job scheduling in breaks, or I allow a client to go over, which means that my typically built-in 10-minute grab some water, go to the bathroom break has now turned into somebody walking out of my office to have somebody immediately walk back in, and then I sit down. And so that's exhaustion for sure. I would come home from those days feeling very, very tapped out. But what I found when I started doing telehealth is that I was also very exhausted, even if I had only seen 4 or 5 people that day. And I couldn't quite understand why seeing fewer people in a day and in an environment that, I was comfortable, it was my home, I was very, very tired. And people were like, oh, we're working from home. And I was all about that at the beginning too. This is amazing. I get to work from home. I get to spend all day with my spouse, who's obviously also working. And then at some point in the last 7 or 8 months, which it's hard for me to kind of recall time, I heard somebody say, we need to stop pretending that we are working at home, and we need to start understanding that we're living at work. And those are very different things to think about. So I'm wondering how many of you have sort of thought about or considered yourself as working from home, if in fact you are working from home. Or does it feel much more for some of you that you are living at work, right? Maybe that story that the previous quote that I put in, maybe that resonates for you in your own specific way. Maybe pieces of it does. But there is an additional, I think, burden that is being placed upon people who are still having to meet the demands of their job, whether that's caseload or other aspects, and still now having to manage the other things that they typically only managed when they got home. And these two environments now being overlapped has doubled, tripled, quadrupled workloads for a lot of people. So some of you maybe have heard Zoom fatigue or whatever platform you use. I think Zoom is probably the most common, certainly in my circle of professionals. That's what we're primarily using. And so according to Jeremy Bailenson, a founding director at Stanford's Virtual Human Interaction Lab, Zoom and other online platforms naturally put us in a position that is unnatural. He says a combination of having prolonged eye contact and having someone's enlarged face extremely close to you forces certain subconscious responses in humans. During normal in-person conversation, eye contact moves in a very intricate dance, and we're very good at picking up on it. So much of human communication is through these nonverbal cues that can be either lost or distorted in a video conference. When one person looks one way, another changes where they look. A small eyebrow raise from someone at the end of the room can trigger a glance between two people. Sorry, I have to move myself around to get to the things. But typically we don't stare into, in this case, clients' eyes up close on a computer screen for an hour at a time. And I know for me, I certainly rely on what people say to me, but I rely very heavily on the nonverbal cues. There have been many times in presentations or sort of speaking with my colleagues that I have talked about a scenario or situation, and I've added the nonverbal pieces of I recognize that maybe their foot started bouncing, or I recognize they were sitting in a particular way. All of the things that we rely on that are not spoken in therapy, and many of us know that sometimes it's the things that are not being talked about that are sometimes maybe need the most energy and attention as opposed to the things that are being talked about. In a scenario in which I see, this much of somebody, and because I work with young people, what I often have are people on their cell phones. And so that cell phone angle is also very distracting. Another thing that I have clients is as they're holding a cell phone, they will accidentally put their hand over the speaker. And so I can see their mouth moving, but I can hear nothing. And so maybe they're in the middle of something and they're talking about something really important or deep, or it needs a lot of empathy and validation, and I'm hearing none of it, or I'm hearing part of it, or I'm trying to find a place to interrupt them and say, I can't hear you, right? And those are things that are not typically happening in a face-to-face office setting because those variables are not present, right? So when we think about what we're doing right now, the demand has changed because circumstances have changed. And even in the context of working with trans or non-binary youth, young adults, whatever the age span it is that you work with, and some of you work, all across the age span, the environment and circumstances in which our clients are living is additive to their experiences of gender dysphoria. And whether they're able to access treatment or they're undertreated or they have a supportive or a not supportive environment. And many of these things we already sort of know because they're also additive to us, right? Many of us are living in a very stressful situation or world, and we're impacted differently. Some people have been impacted profoundly by this pandemic, and others of us maybe have been impacted less. And so those are important things to think about. So, the one of the things that obviously COVID and the pandemic has impacted people, but increased attention to Black Lives Matter, and police state violence, right? That this is, we don't sort of think about like, if you're in my experience here in Los Angeles and my client base, not surprisingly, as a white clinician, a lot of my clients are white, and that there is a specific way in which I think white people are being impacted by the highlights and the increased awareness to our worlds around police and state violence, particularly to Black and brown men specifically, but also women, as we know. And so I have found that clinically, my white clients are bringing new and different conversations in because they have an increased awareness, like it's come like really full force for them, and it's dysregulating in ways that I have found some of the clients that I have who are Black are talking about, like, there are differences, but there's not these huge differences. And I have a lot of white clients talking about, oh my gosh, right? And so we have to sort of adjust to that. Climate change, right? Sort of issues that are on the macro and the larger scale that are very present and dominant in our culture and communications and our political sphere right now is a huge deal. And I'm going to talk a little bit more about this in just a second. The political environment before COVID. I have a client who I was speaking to the other day who is 15. And he was really struggling, not with gender dysphoria, but he was struggling with just an overwhelming sense of disappointment and hopelessness about the world that he is going to launch into as an adult. And we were talking about at 15, his political experience has largely been under this current administration, and that he didn't have a lot of point of reference around the previous administration and what the world may have looked like specifically for trans people, because he was young and he wasn't really living in a gendered world as he is now as a young teenage transmasculine kid. And so for many of us as adults, we have things that we can sort of compare and contrast. But I think for a lot of our teenage clients, they don't have anything to compare and contrast it to. Their only experience is this current political environment. And there is a level of frustration, but also just profound hopelessness that I am seeing in my clients. The political environment since COVID, right? That there are a lot of people who have felt significantly gaslit by this administration's response to COVID. That as trans and non-binary people, that have been some very specific targets and around like our safety and our well-being, and even how we are defined, that gender identity is defined as one's legal sex as designated at birth, and obviously the struggles and issues with that. And there's a real sense of hopelessness, even like how to address that. There's these big things happening on a federal level, and there are clients, who sort of feel like I'm one person living in my one family and my one neighborhood, and that disconnect between feeling, how do I do something about this that's happening on a federal level? People have talked a lot about feeling disempowered in that process also. And obviously isolation. Again, people are isolated in different ways. Some people are isolated more than others. The majority in California anyway, I can speak to, the decision was made without a lot of, from a state level, from not a lot of conflict around, like, we were not going to send kids back to school in person. Within each county, certainly there was counties here in Los Angeles that had big feelings about, sorry, I got 4 minutes ago, I got a text from my wife telling me to do something, to move the screen. Is that, if someone can send me a chat that if you need me to do something so you can see the screen better, that would be really helpful for me. So lost my train of thought. So isolation is, so in California, there was a lot of clear communication that we were not going to be going back to school in person. And there were mixed feelings about that. I think Joe mentioned that for trans kids, there was some relief around that of like, oh, thank God school's not a safe environment for me. But on the other hand, those same clients of mine would say, however, it is the only place that I have one or two or a group of friends who's really affirming of my gender. And so there was this mixed relationship with, I don't want to go to class and interact with teachers, but then I'm also not going to be able to interact with my peer group. And so there was both this simultaneous relief, but also grief that was happening, that was coexisting for people. Joan mentioned this also, like whether you are, sorry, I'm looking at chat. The side boxes with panelists is blocking top. Okay. So, is that better? Joe just realized it's only on her screen. Okay. So Joe mentioned that we need to be asking and checking in about how people are impacted with COVID as it relates to, you know, have they lost their job? Are they, is their job in jeopardy, et cetera? And many of our clients are in that same position. Fantastic. Thank you. So many of our clients, many of my clients are working jobs that were both considered essential workers, but also fell in that category that also were closed, right? So I think about Starbucks is a great example, right? Starbucks may be essential to some people, but when everything closed, so did Starbucks and so did those sorts of services. And a lot of people either lost their job or it was unpredictable when they knew they would go back. And then when California started rolling out the first wave of kind of reopening things, Starbucks reopened, but at really minimal staff because there was no in the building dining. Everything was taken out, right? And so I had a lot of clients who were very, very nervous about sort of what their employment looked like, particularly if their employment was the provider of their insurance, and most specifically, if they were in the process of pursuing any transition-related surgery. And that concern wasn't just about if hospitals were going to continue to perform surgeries, because transition-related surgeries early on were seen as non-essential, and so a lot of surgeries got canceled or delayed. But if you were fearful of losing your job, which then you would lose your insurance, it didn't really matter so much if hospitals were doing surgery or not, because you didn't have the insurance to get that said surgery. So there was a lot of concerns on many levels around employment. Obviously, again, housing concerns. Here in California, there was a freeze put on the eviction, so you couldn't evict people, and we were still under that freeze. I had a client who in January, after a lot of contemplation, decided to move into a different place, a larger place with his partner and two roommates. And so these 4 people had signed a year lease, and all 4 of them lost their jobs when the pandemic hit, and they had just signed a new lease. And their rent was much larger, which was much more because of the size of the place they were living in. And so while it was great that they weren't concerned about being evicted, their rent that was due every month continued to just pile on, right? And so it's not like they forgot the rent. There was like, well, now you owe, you know, this month you owe $3,000, and now next month you owe $6,000. Now we're at $9,000. Now we're at $12,000, right? And we are many, many months into this pandemic, which means he specifically now owes almost $15,000 in back rents because unemployment was not enough to cover both his living expenses, housing expenses, but also the other things that he needed to manage his life. And so he was doing things like rideshare, et cetera, which was not bringing in a lot of income. And so there's a lot of concern that when his lease ends, right, and he has to move because he doesn't suspect that person's going to renew his lease, which is not technically being evicted, he's not going to be able to rent someplace else. And so somebody who was stably housed in January is now facing potentially homelessness. So he's now purchased a van, preparing to do van life, which is way outside of what he thought he'd be doing at 32 years old. Food instability, which Joe obviously talked about, unhealthy or unsafe living arrangements, right? There are people who are experiencing domestic violence, sexual assault, and early on when there was, you know, stay home, don't go anywhere, it put folks who are living in unsafe environments in a real precarious situation. And then, I've alluded to this, that there is a real feeling of hopelessness that is permeating all age groups all the way down. But I think that there's something specific about teens and young adults. I think there is just this level of like, what's the point? Is there even going to be a planet that is around by the time I get old enough, etc. Just reading the chats. Yeah. So just speaking to that level of exhaustion. Yeah. Absolutely. Compassion fatigue and other trainings. I mean, even engaging in trainings, like as a trainer, maybe some of you have seen Joe and I present in person, and it's invigorating, it's rejuvenating. But training in this platform, I also find to be very challenging and somewhat depleting. And so all aspects of our lives, I think, are challenged by this platform, as certainly mentioned by Jessica. Okay. There is many clients and young people in my personal life who, when they speak of feeling hopeless, that there is a certain anger to it, that there is a frustration to it, and there is a real sense of there's no point to even talk about this because nothing's going to change, and they're unable to anchor to maybe the impact of what a year could look like, 2 years could look like, because when you're 15 or 16, 2 years seems like a lot. As an adult, we realize that 2 years is a very short amount of time. Cool. Thank you for those resources. All right. So living at work, let's talk about what that looks like. We are negotiating privacy, our privacy and our clients' privacy, right? So in this context, people are now in my physical space with me. We recently moved to better accommodate this probably long-term working from home. I gave up my office. I have no physical location to go back to, even if I could or if I wanted to. And so when you have multiple people working at home, or you have one person working at home and other people in the environment, there are privacy concerns, like HIPAA privacy concerns, but there's also privacy concerns about people entering into our private spaces. So I had a client who, the flow of our work was very predictable, right? That we had gone into a pattern, and week by week, we sort of continued the conversation from the previous week. We had identified some clear goals that they wanted to work on. And then one week it sort of seemed like there was a departure, and I couldn't quite organize and figure out what exactly was going on. And there was 3 or 4 sessions, and I remember sort of being perplexed at my own experience of like, but just be here, be present. This is where the client's at. This is what they need to be talking about. And then one day, I think maybe by the 4th session, I was like, I just have to check in. It really seems like we, about a month ago, kind of did a departure. I just want to check in and see what's going on. And they leaned into their computer and very quietly whispered, I found out my mom has been listening at the door during our sessions. And so they, in a way of sort of setting up their mom, started talking about things that were not what we were talking about before, to preserve this person's privacy, but to intentionally kind of poke and prod a little bit at the parent, because they knew the parent were hearing things, and what the young person was talking about wasn't entirely accurate. And so like those were things we had to navigate, and we had to talk about, A, how did this person find out? B, what do they want to do? Like, what's my role? We had to spend a lot of time figuring that piece out. And ultimately, obviously, communication had to go to the parents, of like recognizing that eavesdropping on your child's therapy is problematic and maybe something they would like to work out in therapy. As I said, clients are now in our homes, sometimes seeing our partners, children's, pets, etc. And while some of us, like, I'm not particularly bothered by that, this is how I would come to work, even if I was working in person. Other than the hat, I kind of have, no access to a barber. So I'm trying to cover my COVID haircut these days. But otherwise, wearing these shirts, etc., would be exactly how I come to work. But there are times where maybe I am home because Joe's, at CHLA in person, and my dog needs out, or like there's a delivery, there's someone at the doorbell, there's these intrusions, the things that happen. And so I'm carrying the computer through my house, and people are seeing different things. How do we manage environmental distractions, some of which may be unavoidable? This video cracked me up when I saw it. I think this is a great example of an unavoidable, in this circumstance, an unavoidable distraction that this woman experienced. So we're going to do fingers crossed that the audio works.
Meditation is great for bringing about a sense of relaxation, well-being, and calm. So starting just quickly by breathing in and breathing out. And it's really challenging, I know, with children home from school and working from home, but just trying to just keep all of those distractions out of the way.
So I really appreciate that while I haven't experienced the distraction of my child in this particular way, I assume that some of you, maybe many of you, have experienced some version of this. My intrusions typically are animals. My cats and my dog have a very clear sense of what time it is to do whatever it is that they want, regardless of my schedule. So, what are other things about living at work? So we're also in clients' homes, right? So I had a young person come to therapy and the camera turns on, and all of my clients go into a waiting room first. So it allows me a little bit more control over the environment. I turn my camera on, I make sure that there's nothing in the view that I don't want in the view, make sure that my lighting is good, all those sorts of things. And then I bring them in to the session. And to my significant surprise, as the camera came on for them, this person was sitting without a shirt on. And I was sort of taken aback, and I sort of was like, you don't have a shirt on, as if they did not know. Like, I clearly was just like processing out loud. And we sort of had to, like, I was distracted. I was absolutely distracted by that. And certainly I know that this person would never come to an in-person session without a shirt on. And so that's an example of how we're in clients' homes, and which means that we're going to experience them in their environment, which for this person, at least in that moment in that day, meant no shirt on. And I had to really come to realize that this was my problem, right? This was my distraction, and it was not his problem or his responsibility, because we absolutely could continue to do the work that we wanted and needed to do. It didn't preclude him or I from having meaningful connecting conversations, but it is an example of how this works both directions. Managing technical issues, right? Many of us have experienced technical issues, and now they're starting to create commercials where they are talking about technical issues. I'm reading the chats. Yeah, I hope people, read the chats, because I think there's really important points that are being made. Yeah, not wanting to end sessions because it's the sort of point of contact, right? They're so isolated that maybe that interaction with you on that weekly basis, or whatever the frequency is their sort of lifeline to people outside the house. Absolutely. Yeah. Yes, I absolutely agree. Thank you, Jessica. So managing technical issues. Some of you maybe have seen this commercial, but I think that Progressive did an outstanding job highlighting this very thing.
Start. Oh, do you want to go first?
No, I don't. You go.
I was just going to be on slide 7, talking about bundling and saving. Jamie, you're cutting out.
I am like, hey, whoever's doing that, can you go on mute?
Oh, my bad. I was just saying there's a typo on slide 7. Bundle home and auto for big disco snouts. I think that's supposed to say discounts.
You sure about that?
Hey, can you guys see me?
I feel like outside of it being Progressive, I have had this experience time and time again. I am very sensitive to being interrupted, and I'm very sensitive to interrupting people. And I have interrupted people unintentionally more in the last 7 months than I think I have ever done in my career combined. And it's because I'm trying to manage the delay or camera freezing or whatever it is. And so there's a flow issue that happens where if somebody's saying something and on my end they have seemingly stopped because there's been a gap in the connection or what have you, I say something and then I only realize they were still talking, and then they stop and then I stop, and now we spent some amount of time trying to like go back and forth of like who it is that's supposed to talk, right? And so there are benefits to telehealth, but there are also real challenges, and I think that that's certainly one of them. Okay, so I want to show also a video. One of the things that I talk a lot about and I'm very passionate about is understanding gender dysphoria as an experience and not just a diagnosis. And Joe and I and one of our colleagues created a very robust 2-day training, and that is like the most significant contribution that I have, is talking in a lot of detail about this. That's very challenging to do in an online platform because one of the ways I do it is through an activity. But I found this video and I felt like it's really important that I just wanted to share it so that I at least get that message that's super important to me in to this conversation.
You can try and just ignore it, but we both know what you look like. But just carry on. Not that. Not that. That will not hide those. No. I mean, sure, if you want your hips to look as wide as a bus. Ooh, that's good. Really? No. Wait for it. Wait for it. There we go. Your voice is really high. I recommend you continue sitting there for about an hour and then go curl up in bed for the rest of the week. Okay?
So our clients are experiencing all of these things, whether they're transmasc or transfeminine or non-binary. Gender dysphoria, the experience, has not gone away. And in some places, in some ways, maybe things have increased. If they're in an environment where their families are struggling with support and struggling with affirmation, there are aspects of their gender dysphoria that is going to be obviously increased because of that. But what are some of the things that I have found that's teletherapy specific dysphoria? This is not the entire list, but it is certainly some of the things, the more common things that I have come across. Dysphoria associated with seeing themselves in the camera. A lot of us are distracted by our own reflection in the camera. I think that it's a very typical human response. Again, sort of thinking about Zoom fatigue, that we're not used to this mechanism. I'm not used to seeing how I speak when I'm speaking, whether that's hand gestures or whatever, right? If clients need to keep their camera off, how can we adapt and work with that, right? There are some clients who will only engage or continue to engage in therapy if their camera is turned off, which, okay, but it also sort of creates this like, gosh, is anyone even there, right? What are they doing? Are they paying attention? It's not uncommon for teens to be in therapy in person and be on their phone or doing things, but at least we can see that stuff and we can kind of manage and orient around what's going on. Reading the chats. Yeah. Okay. Other pieces. Let's see. I'm gonna close the chats. Hearing their voice in their computer or headphones, right? That, as we know, a lot of both transmasc and transfeminine and non-binary folks have a lot of voice dysphoria, right? There's a part of dysphoria is this relationship of not enough and too much. It is a real struggle for people, regardless of where they are in transition, to find just right amount of whatever it is. Like, that's the sort of the beast of gender dysphoria that is part of the ongoing experience of it. And so some clients may speak less or avoiding speaking altogether or rely really heavy on chat. And as you can see right now, managing chat and talking and doing things like chat in and of itself is a really important function, but it's a different way of interacting with people. I co-facilitate a support group at one of the universities here, and we have a student who is so dysphoric that they absolutely will not speak at all, and they do their entire process on chat. And so you have a group of people who are talking and sharing, you know, the challenges of being back home away from university, and this person's typing all of these things, and there is a flow disruption. And so we had to figure out how to work around that and be very clear whose problem that was. Another thing that I've done is shorter visits. I have some clients who they just cannot tolerate being connected in this format for 15 minutes. You know, someone mentioned earlier, and I mentioned that there's a different kind of exhaustion. Our clients are experiencing those same exhaustions, especially now that school has resumed. And if they're spending 4, 5, 6, 7 hours on a Zoom platform, another 50 minutes with us may not be the best use of that time. And so we're doing 30-minute appointments, maybe a little more frequently. So how do we work with those things? Lighting issues that may be masculine, may highlight masculine or feminine features, right? So there is a relationship. If you see yourself, you can also see, you know, your face structure, if you have facial hair too much or not enough, right? If you have an Adam's apple, if you have a perceived masculine or feminine shape of your face, people who have a lot of face dysphoria. This has been severely increased because they'll lean into the camera and they'll point out and try to show me the pieces of their face that are either feminine or masculine. And so I'm finding I'm having conversations that are a little bit different. So the reality is that for me, at least at this point, I feel like there are more questions than answers. How do we work with these new, and for some of us, and me included, it's starting to feel old challenges and not around them. I think that we have this proclivity of like, well, let's work around this and let's do this and let's do this. And maybe we actually need to figure out how to work with, because I suspect that even when this pandemic looks very different for our world, and maybe we start re-engaging in things that are more familiar to us and sort of how we do these things, I do suspect teletherapy is going to be around. It is going to be a new tool that is used for people who, even if they could go back to in-person work, may not choose to do that outside of a pandemic. So to be continued, I suppose, would be the next thing of maybe, you know, 6 months from now or a year from now, we come back together and maybe we have more answers than questions. But for now, we do have just, you know, a few minutes. I know not a lot of time for questions. Yeah, any questions that people have or comments? I know that we are rolling up on about 2 minutes before we are out of time. So Sarah, I don't know if you have any closing remarks.
Yeah, I really just want to thank both Aydin and Joe for spending this time with us today and for speaking about this really, really important topic that is close to a lot of our hearts. So just really want to thank both of you and say that if you're interested in future trainings from the Central Texas Transgender Health Coalition, go on over to our website and you can sign up to join our email list if you're not already on it. And we'll be bringing other educational opportunities such as this your way in the coming months and years.
Thank you for having us.
Of course.
All right.
Thanks so much, everybody.
Bye, everyone.
All right, we might have 2 new comments or 2 messages. I think they're just thank yous. So once again, thank y'all so much. And thanks to our participants for your time. We're making history here. Bye-bye.